Hi, welcome. Today is session three talk on from GRSP 2022-2023 session. I'll be talking about today about different study types and then research questions. So I think just following where we are in program and how you create an hypothesis, data type, study type, and then some Q&As and maybe a to-do list in the end. So you might have seen it if you're part of GRSP already in different session. We are focusing on this area and then probably trying to get this another lecture with hypothesis, data type, and study type. You had at least a couple more lectures and then guest lectures already. Today's focus in these three areas are how to come up with a hypothesis. If you're doing a clinical research question, it applies to systematic meta-analysis, two different data types and study types, just an overview of those things, which help you a lot. The research hypothesis by now, you have been in a couple of months, and then those will be watching it later on. It's a specific version of your research question where you use your patient sample, your predictor variables, your outcome variables, and then kind of form a statistical significance around it. Let's take some examples right there. Hypothesis, if I divide them into two parts, simple hypothesis and complex. In simple, you take one predictor variable, smoking or lung cancer. In this case, I use that if the sedentary lifestyle is associated with increased risk of proteinuria in diabetes patient population diabetes, sedentary lifestyle is your predictor and one outcome is proteinuria. If I make it complex, more than one predictor or more than one outcome. Sedentary lifestyle and alcohol consumption, two predictors and predicting proteinuria. If you change it, and you can have more than one outcome as well. That makes it a complex hypothesis. At your stage, please follow a simple hypothesis. You can have more than one hypothesis as well. Null hypothesis, you say there's no association. You always try to think that there's no association. What is you're trying to do is you're trying to prove that there's an alternate hypothesis. There's an association between a predictor, smoking and lung cancer, or a sedentary lifestyle and proteinuria, and so on and so forth. Sometimes they are one-sided, sometimes two-sided. When you have commitment phobia, you just say, you know what, I don't know which direction it's going in, and you just say that, you know, there's some association, or sometimes you say, yes, it helps, or this thing causes problems. So that is your one-sided hypothesis. Two-sided, you don't know which direction, you just say there's some association and that's it. So to give an example, and I bring it from pulmonary area as well, so your research question could be that whether there is a difference between the efficacy of salbutamol or ipratropium bromide for treatment of asthma. That's a simple question. You're looking at two different medications to see how efficacious they are. You create a null hypothesis around it, and I want you to do that mental exercise. There's no difference in the efficacy between these two things. That's your null hypothesis. What your alternate hypothesis could be, you say that there's a difference between these two. If you're not committing, that becomes two-sided. But you're saying that, you know, salbutamol is better than ipratropium bromide, or ipratropium bromide is better than salbutamol. Then it becomes a one-sided hypothesis. You think about question, you think about null hypothesis, and mostly you're writing your alternate hypothesis, and you don't say alternate hypothesis, you just say that's your hypothesis. So null hypothesis, you think in the brain, and then you only write a alternate hypothesis, and then given that you're writing it alternate, you just mention it as a hypothesis. We talk about two-sided and one-sided. You know, two-sided is that there is only one possible. One-sided is only one possibility. Two-sided, each one is possible if you don't know. And then usually two-sided is conservative, but I'm not a huge fan of it. You know, usually you will know from literature, or you will bring on your ideas then how these things work. So I would like you to think about having a one-sided hypothesis if you're designing a clinical research. Let me jump into the types of variable, because you hear me say that your statistical analysis depends on what type of variable you're using it, nominal, continuous, and so on and so forth. Let me give you small, like maybe 2 or 3 minutes of a little bit of knowledge. If you divide the variables into two major categories, numeric and categorical, and then numeric and categorical, they divide again further. Numeric divided into continuous and discrete, categorical into ordinal and nominal variables. For all practical purposes, in your lifetime, 90% of the time, let me hear it say it again, 90% of the time, most time you'll be using either continuous variable or nominal. This will cover 90% of a variable all the time. In some capacity, maybe ordinal, and that's it. You don't use discrete too much. Okay, so let's focus on this part, categorical variable, how they define ordinal and nominal. I'll give an example. So nominal, there is no categories. The blood group A, B, ABO, that's your nominal variable. Different types of eye color, different states or different countries, they all are nominal. There's no category around it as well, or hair color for that matter. Or if you use male, female, gender, or something like that, if you think of that, married, unmarried, all are nominal categories. Ordinal, there is an order. So example is your pain scale, Likert scale, residency, liking scales, and things like that. Those are your ordinal variables you'll be using at the time, and you'll report them as a mean, median, and things like that too. Or there is an order, 1, 2, 3, no pain to blah blah, strongly disagree to disagree. That'll be this way, and then different spice levels and things like that too. So nominal, there is no categories, male, female, alive, dead, all those are nominal variables. And then ordinal, there is an order. They both go into categorical variable category. Then focusing in numeric part of it, continuous, it's easy. Your height, weight, time, length of stay, length of mechanical ventilation, hospital length of stay, weight, whatnot. Anything which can be infinite number of values in theory, but you still have a limit. It doesn't matter. Those are your continuous variable. There is a continuity of every point is possible in weight, every time is possible in weight, and in time. That's a continuous variable. Discrete, which you'll never let see me speak it. That is something which is defined. That's how many cars were sold per month at that company, how many houses per city block, and how many fishes in one fishing trip. Usually you use discrete variables when you are doing public health things. How many patients per city got infected with COVID-19 or SARS and things like that. I don't use it. If you are studying the whole world's population, whole city's population, you may get by just giving the discrete values. But other than that, I don't have much value for you when you're doing medical research. So focusing on continuous and numeric nominal variables, and some part is ordinal if you're doing Likert scale surveys and things like that. Okay. So now just to introduce, you hear me talking about cause and outcomes, and effect and outcomes, and cause and what is happening with that part. So a predictor is a variable that causes or predicts the outcome. It has to come before the outcome. Smoking can happen first, then lung cancer come in. Okay, you can't count people who have smoked lung cancer and then started smoking. That doesn't work. Outcome is a result of the effect. So you're looking for drug A, drug B, drug C, and your outcome. Some of the examples are you're looking for, let's say, sleep disturbances among providers, and then you're looking for anxiety. That has to come. People can't have anxiety and then have a sleep out disorder. That's a different question. Your question is sleep disorder comes first, and then there is anxiety or burnout and things like that. So that you have to always think of relationship, that cause has to be first and effect has to be later on. There's a confusing example I'll give you. Watching TV and obesity. It could be both ways. Depending on a question. You're saying, is watching TV causes obesity? That means you take all people who are not obese, see how many hours of TV watching is happening, and then you measure their BMI over 3 months, 6 months, 1 year period. That's your research question. Or you say, what does obese people watch more TV? That's a different question. Then you start with obesity first, and then you see obesity, non-obese people, and then you see what is the watching TV, because they don't want to go for bowling, running, and all those things in a sense. So it is a pretty fascinating part, that how question changes, but until you understand that what is my cause and what is my effect, that will save your life. That's like holy grail, Bible or Quran of research, where you talk about it, that it's a cause and effect. And then there's a confounding variables and other things as well, but that's your timeline, that cause and effect. And then once you know that, you can write your hypothesis, you can write your title, you can write everything once you understand what you're trying to study. Okay, now I'll jump into study types. What different types of studies you either do, or you are including your meta-analysis or systematic reviews and things like that. Observation studies are two types. Then you're drawing the inference. There's no intervention. You're just observing what happened, and then you're putting into different types of studies. One is descriptive. There's no analysis. You looked at 100 patients, and this is what it was. You're just describing them in a table. There is no meta-analysis. There's no analysis which is being done. Once you get into analytical part of it, then you're trying to characterize an association between predictor and outcome. And then you start seeing the table where you have the control group and case group and p-values and all those things. You get into the analytical form of it, and I'll spend a little bit time on analytical part of it, because that's going to be main part. Sometimes we say just descriptive study. That means you don't have any hypothesis, you're just going to describe it. Well, you can still have a hypothesis, but there's no predictor and outcome variables there. You're just saying my hypothesis is describe the population, describe the incidence, describe the prevalence, and so on and so forth. Okay. Cross-sectional versus cohort study design. If we go into the cross-sectional, is like everything is happening at the same time, or both predictor and outcomes are measured at the same time. Okay, so where the measurements of study are done on a single occasion in a short period of time, that's your cross-sectional design. Cohort, you may follow the patient for a long time, either retrospectively or prospectively. Look at the patients who got certain disease during the pregnancy and then followed them on for 9 months. That's your cohort study design. A patient is coming to your clinic and you're measuring their blood pressure and measuring your proteinuria. That's a cross-sectional design. You're saying that what's the association between these two things. That's your cross-sectional design at the same period. Cohort over a period of time. So you do one measurement, that's your cohort cross-sectional design. When you do multiple measurements or measurements over the time for a period of time, that's your cohort study design. Example is there, body weight, blood pressure, measure at the same time as a cross-sectional design. If you measure them multiple times and look into it multiple times at different time points, that becomes a cohort study design. So cross-section is nothing but a cross-section of a study at the same time. If I cut these things and see how different they are if where I cut it, so cross-sectional have their own limitations. We are not going into detail there, but it just gives you the one snippet or one window into the population piece at the time. Okay, so it gives you some information, but if you cut it different places, you might get a different population with different information from the same population. Okay, cross-sectional, you are measuring it. So if you think of today, you are here, you are looking at the patient population, you take a sample, then you measure the current variables, and then you look at the part of it. You're in patient population, you take a sample and you looking at the disease and exposure, both outcome and exposure at the same time. That gives you the cross-sectional idea as well. You're not doing multiple, but you can describe the variable, and sometimes these could be hypothesis generating that can give you an idea to do a better study later on. Okay. Cohort design, we talked about it. Prospective cohort, you pick up the patient now, you follow them over the time. That's your prospective cohort. Or you look at after 2 years through medical charts or phone calls, or actually following them, like finding them, what happens with them by asking them in a sense. Predictors of the outcomes are measured beforehand, like you measure them now in present time, and then you follow them over time for the outcome piece of it. Okay, these are a little bit expensive when you compare to cross-section because there's a time frame as well, but you can do a multiple variables. In cross-section, you're usually doing one variable, one cause and one effect, one predictor and one outcome. Same thing, cause, predictor, effect, outcome. Those are, I'm using them interchangeably. But in prospective, it's expensive, but it gives you to study multiple variables because you can measure them. People are more likely to answer. Remember, there are multiple positives around it. Negative is it's expensive, it time consuming. Retrospective cohort, you look back in time. You go back and measure the exposure or cause first, and then look at the outcome. Both can happen in the past. Okay, you save time, it's least expensive. You use most from electronic medical records or databases as well. And sometime you can study more variables, but you have less control on the variables because it has already happened in the past. And then you don't know what are the known and unknown confounders. That's the biggest challenge with the retrospective cohort, but that's one of my most favorite study design. It's least expensive. You can do a lot if you're in residency, in fellowship, or if you're working in a hospital. This study design where you can get the data automatically would be your to-go bread and butter study design for that matter. Case control design. In that, what you do is you do reverse. You measure the outcome first. You look at the people with cancer. You look at the people with whatever disease. You find this matching controls who did not have a disease. You go back in time and see who had the exposure. Don't take me wrong. Exposure has to happen first. Outcome has to happen later. But where you start everything else, you're starting with exposure first, then look at the disease. Here you're starting with the disease first, and then go back and see who got the exposure. That's your case control design. The biggest strength of case control design is that you save time, and it's done for the rare diseases. That's one of your USMLE questions, and most of you have taken the exam, you would know they will ask this question in AMC and other places, or PLAB and all. That's a question that where the case control design is the best design is for your rare diseases. And then it's little less expensive because you're looking at the data in the past as well. So same thing, you look at the patient population, get the cases, get the controls, and look back at their outcome in the past. Case control studies cannot be done in prospectively. They're always done, always retrospective. They're inexpensive, rare disease, they are retrospective in design, and then they're used for generating hypothesis. That's the one thing I just want to make, and I mentioned that in your descriptive study design as well. You have heard me say PICO multiple times. PICO stands for patient population or participants, intervention or exposure, controls, comparison group, and outcome. Intervention or exposure, I mentioned it, or control and outcome as well. So just keep in mind, anytime you're asking a question, you can always think it. Sometimes it doesn't apply. If you're doing a research study on social media and things like that, it may not apply completely, but at least all different types of studies, systematic review, meta-analysis, cross-sectional study, your retrospective, prospective, cohort study, case control design, all you can apply PICO questionnaire as well. Let me give you a summary of this, which I talked so far is. So this comes from the book, and this is called Designing Clinical Research book. All my teaching comes from that book. I have read it multiple times, and I ask my students to read it all the time. When in one of the major institutions, when I used to train critical care fellows, that was a thing. They should finish the book in 1 month. It's so easy to read. In 30 days, you can finish the whole book. So on the top chart, it's your clinical trial, which we have not talked about. Let's start from the bottom. So cross-sectional design, we talked about. If you pay attention to past, present, and future, we are in all in present. I mean, some of you might be in past, or some of you might be daydreaming in future, but I am in present. Cross-sectional design, you look at both risk factors and outcomes in the same time. We did talk about it. It's cross-section at the time. Case control design, I talked about. You start in the present with the disease and non-disease and look back into their risk factors. That's a case control design. Retrospective cohort design, you are in present. You go back and check the risk factors and outcomes. They can happen in the past and present as well, but you're looking at retrospectively. Everything has already happened in the past. Prospective design, you start with the risk factors now, you follow them, and then look at the disease and outcome in future. That's your prospective design. The concept of risk factors and disease, risk factors of disease doesn't change anywhere. It's the same thing. Only difference in case control, you start with the outcome of disease first. Clinical trial, we have not touched upon. We may have a class in the end where you are actually giving people treatment. You're randomizing them or non-randomizing them, but actually creating an intervention. You're not mere observing it. They are only and only done in future or present and future. So you can't do retrospective clinical trials. And then you look at their outcomes in future. So, and we can send you this picture. You can take a snapshot of it if you like to, but it's there in Designing Clinical Research book. And then that book, there's some sort of PDF is available as well. You don't need to buy it if you can't afford it. Time is key, as I mentioned. This was a part of picture I was showing you. Case control, both happen at the case control design. Disease happening now, you go back into the past as for exposure. Your cohort design, usually you have the exposure first and disease later. The exposure first and disease later. It can happen prospective, retrospective, cross-section, both are happening at the same time. Just a repetition of what I just said. The probably last slide for today is I'll give you a cheat sheet where if you don't know what kind of design is, you can ask this first question. Am I comparing 2 or more groups? The answer is no. Then probably you're writing a case report or case series. There's no group comparison. If answer is yes, then you have to identify what is your exposure or cause or predictor, and what is your outcome or disease or outcome. Then you determine which was determined first for the study. If you determine your exposure first or predictor first, and if you are assigning by yourself, that's probably you're designing clinical trial. That means you're not mere observing it. But if it's not designed by you, it's not assigned by you, then exposure, that means you're doing a cohort study, either case control or either cohort study, either prospective or retrospective. If outcome is determined first, as I mentioned, then this is a case control study design. If both of them are determined at the same time, then it's a cross-sectional design. And there are a few other variables of social media research, and then your survey-based design research and things like that, and some of the quality improvement studies, and then some of the qualitative studies. But at least this covers 70 to 80% of the workload you'll be doing it in your lifetime. 70 to 80%, even 90%. This particular graph and checklist where you can follow the branching logic. So with that, I think for you to do this is, if you've not watched already, how to write background, how to start systematic review, and how to write hypothesis, I would really want you to watch it. You can use into your proposal what you have already written, or when you write the paper. Create your social media profiles. If you're not active on LinkedIn, Twitter is dying off, but at least LinkedIn for that matter. Create the profile, have the same picture everywhere else, so you're creating a branding as well. And you finalize your ideas, and based on what you learned today and watching the videos, finalize your ideas, write them into a background and hypothesis and method you can actually write down and add them to the Google Drive. So with that, I'm going to stop this video. Watch it again. Those who are not attended today, it'll not be a bad idea for you to watch it and then rewatch it as well.